So the most common tumor that you'll end up seeing in the oropharynx is going to be squamous cell carcinoma. But on the other hand, realize that there's other types of soft tissue in the oropharynx that's going to predispose you to other types of tumors. And the way that we can sort of remember this is by this famous person called Wilhelm von Waldeyer-Hardt. So you guys probably know I have a penchant for the history of radiology and the history of medicine. Well, Waldeyer-Hardt was the first one that described lymphoid tissue involving the lingual tonsil, involving the palatine tonsil, and then also this adenoidal tissue involving the nasopharynx. So when you look in someone's mouth, this ring of lymphoid tissue is what we lovingly refer to as Waldeyer's ring. So as the result that there's lymphoid tissue that's located behind the tongue base and kind of situated right here in the vallecula, the second most common tumor to involve the tongue base is going to be lymphoma. And this is just a T1 weighted image with MR with contrast, demonstrating this nice little lymphoma right here that's tucked into the vallecula. Now, the challenge that we get into in the real world is that, remember, I mentioned that there was lingual tonsillar tissue right here. Well, sometimes this lingual tonsillar tissue can get inflamed, and you actually get a tonsillitis. Now, we'll be talking about the tonsils later, but the point is that you can get a lot of inflammation in this lingual tonsil, and then when you look at it on cross-sectional imaging, in this case, a T2 weighted image, you can see it's very bright. It's kind of nasty looking. But it turns out all this is just inflamed tonsillar tissue, as we see here. And what's really challenging is that when you look at the sagittal images on the CT scan, boy, this looks a heck of a lot like what I showed before. So what do we do in these instances? Well, I see this every day. And fortunately, because I end up seeing patients on Wednesdays, I know that this is a very easy area to look and to palpate. So if I'm not sure about this, I'll go ahead and mention there's increased soft tissue in the region of the lingual tonsils, and this area can be evaluated with direct visualization and palpation, similarly to like you're looking at someone's mouth. So when you do get into this conundrum, just realize, fortunately, this is a very easy area to see. So this is the typical thing that we'll see. This patient and this patient both have an abnormality involving the lingual tonsils. In this case, it's squamous cell carcinoma. In this case, it's lingual tonsillitis. I cannot differentiate these two, so all I say is just look at this directly clinically and with palpation. And when they see this, in this case, they'll be able to properly diagnose the squamous cell carcinoma. And in this case, they'll be able to properly diagnose the lingual tonsillitis. Now, the third most common tumor to involve the tongue base is going to be of minor salivary gland origin. Now, why is that the case? Well, the reason is that when the head and neck is developing, the majority of the mucosa is going to be basically epithelial tissue. And also, you're going to have muscles and so on and so forth. But as the head and neck is developing, there are certain areas where you're going to have a higher incidence of minor salivary gland tissue. Now, what exactly is a minor salivary gland tissue? We know about the major salivary glands. So we know that there's parotid glands, we know that there's submandibular glands, and we know that there's sublingual glands. When you have salivary gland tissue in the proper location, we just call those salivary glands. But unfortunately, as the head and neck develops, sometimes that salivary tissue can end up in the wrong location. And if you have salivary tissue that's not located in a normal salivary gland, then we call this minor salivary gland rest. There are certain areas in the head and neck that have a higher incidence of having higher proportions of minor salivary gland rest. And those areas include the tongue base, they include the soft palate, as we'll see later, and also the hard palate, which is part of the oral cavity, which we won't discuss. But because of this higher propensity of this minor salivary gland tissue to be situated in the tongue base, then these can go on in rare occasions to develop minor salivary gland tumors. And in this case, this is an example of an adenoid cystic carcinoma. And this is another malignancy which is somewhat unique. And I've just saw a case of this last week in tumor clinic as well too. This is the polymorphous adenocarcinoma. Now, there's no way that we can really differentiate these two. And the only thing that I can tell you that I can help differentiate me, that I can use this, I should say, is that if I see a mass right here and the surgeons look down and they just see everything is submucosal, that is more suggestive of a minor salivary gland tumor. But as opposed to the regular imaging findings, maybe if you see something that's high signal on T2, then you can suggest maybe a pleomorphic adenoma. But in general, I find the imaging findings to be nonspecific. So when we talk about the tongue base, remember we talked about the thyroid gland. So the thyroid gland starts at the foramen cecum, then it has this relative descent, and it has this very complex relation to the hyoid bone, but eventually it ends up in the normal resting place. So in the context of this talk, if you have thyroid tissue that sort of gets stuck in the tongue base, well, we can develop this thyroglossal duct cyst. So the thyroglossal duct cyst end up being right here at the level of the foramen cecum. And the classic procedure that's performed to resect this is called a cyst trunk procedure, where the surgeons make a midline lesion, excision, and they take a cuff of tongue-based tissue. Now, on the other hand, if you have solid tissue, then this is what we refer to as a lingual thyroid. So the lingual thyroid and the thyroglossal duct cyst are related. It's just that the thyroglossal duct cyst contains thyroid tissue that you end up having fluid within it. Whereas if you have something solid, then that's a lingual thyroid. And the way that you can be comfortable with this is that you can perform a CT scan. If you see no uptake right here, that's one thing. That tells you that this is probably all lingual thyroid. Secondly, is that you can actually do a thyroid scan that would just identify all the uptake here in the region of the foramen cecum. And thirdly, this can be detected clinically. Again, we had a patient in clinical about 3 years ago, and the surgeon actually properly identified that it was a large lingual thyroid because it was hypervascular. So just remember, when you have these lesions involving the tongue base right here, especially when they are hypervascular, because we can see this enhancing similar to the thyroid tissue, you should include this in your differential.